Recording in progress.
Hello, everybody, and welcome to the next week in psychiatric nursing. I am Heather Ranillo. I am your facilitator for this course this semester. This is Peanut. He likes to hang out with me when I do my schoolwork. He's very needy. So, in order to be successful in working with any patient, it is necessary to develop a therapeutic relationship with that patient. And this week, you guys are going to be exploring therapeutic relationships in your guided reading that you will be doing. This relationship is based on trust, it's based on empathy, it's based on caring. It is through your words and actions, as well as your silence, that you communicate to the patient that he or she is important and that they are opening up their needs to you. A therapeutic relationship is one that is focused on the betterment of the patient. It's based on a purpose that leads toward a goal in like a set time frame. Okay, and we're developing this relationship in which both the patient and the nurse are going to set the agenda. And I never know where the camera is. I'm assuming it's right there, but my Zoom screen's like over here. I'm not a boomer, but sometimes technology. Like, so the patient and the nurse set the agenda. It's not done for the patient. It's a collaborative effort with the patient, and it flows through 4 identifiable stages. Okay, so we'll go over the phases of the nurse-patient relationship as we get further in our reading. All right, so a memory jogger. To encourage your patients to trust you, you're going to think of the mnemonic trust. So T, try expression. Reflection, R. U is the use of silence. S is for setting limits. And T is for the time with the patient. So the phases of that nurse-patient relationship. The phases of a therapeutic nurse relationship include pre-interaction, orientation, the working phase, and your termination phase. So pre-interaction phase is when it's like, it can last anywhere. It can be like a few seconds that you're in a client's room, or it could be several weeks if you're working in outpatient. The nurse is assessing the patient for their unresolved problems, and the patient may not be actively involved at this point. And then orientation is like your introductory phase. In the orientation, it's the getting to know you phase where we're setting the tone for the relationship. Introductions are made, each person's role is defined, and trust starts to develop. So usually the nurse initiates this phase, sets time limits of the professional relationship, and establishes the focus of the conversation based on that assessment data. Then the nurse and the patient may make an agreement. They could write a contract, they could discuss and establish goals, but be aware that some patients may be resistant during this phase, testing your intent and denying that they even have a problem in the first place. Then we go into our working phase, our exploration phase. And during this working phase, the nurse and the patient explore and evaluate problems and work toward achieving those set goals. The nurse may take on the role as a listener, may take on the role as a facilitator, and the patient is participating actively. The patient's free to examine problems while trying to gain insight and find solutions. And then we have our termination phase, which is the resolution phase. And during the termination phase, the nurse reviews and summarizes that patient's progress. And together, they determine were the goals met, and if they weren't, why weren't they met? Then the nurse formally ends the relationship, being sure to acknowledge the patient's feelings about the termination, being aware that the patient may feel hurt or angry and may feel like the person has abandoned them. This can even happen within a 12-hour shift that you are establishing care with the patient, and then they build this rapport and relationship with you, and then your shift ends and a new nurse comes in and it starts it all over again. Which is why it's nice that when you work back-to-back 12s that you get the same patients again. So effective communication, so effective therapeutic communication is essential in psychiatric nursing. Verbal and nonverbal communication involves sending and receiving messages. Body language sends volumes of information both to and from your patient. You don't want to stand there with your arms crossed. You don't want to stand there fidgeting with stuff. You don't want to be playing with a pen while you're trying to talk to the patient, okay? Because this is important that to be very aware of the messages that you send. Communication exists in spoken, written, and unspoken language as body language. Nurses rely on multiple forms of communication to provide information to patients. We often educate our patients on appropriate behaviors or treatment options and provide written documents to educate them on treatments upon discharge from the facility. So we want to minimize obstacles. It's important to remember that patients have biases and they have beliefs just as we do. And in order to communicate effectively, it's important to understand the cultural, the ethnic, the religious, and the educational biases that are all potential obstacles. And your sensitivity to your patient's beliefs can improve your ability to connect with your patients. So we're developing a therapeutic relationship with a patient with a mental health condition. Now, this can be really challenging. Patients have thought disorders, they have dementia, they have mood dysregulations that can impact their ability to engage in therapeutic communication. And then not all patients speak the same language as the nurse. And the Joint Commission requires that hospitals provide interpreters to assist patients with communication. Many hospitals have interpreters among staff or use language lines when interpreters are not available. Sign language interpreters can assist with the hearing impaired as long as we have the right equipment. And there's also the telephone machines that can facilitate communication with patients. And it's important to listen to not only what the patient is saying, but how is the patient saying it? Looking at their speech patterns, looking at the intensity of the speech. And when we start talking about manic depressant and flight of ideas and ideas of grandeur, this intensity of the speech will come into play. We're looking at the logic of the conversation, and it provides a wealth of information about the patient and his or her health. So what can affect communication? Various factors hinder communication, right? Things we're looking at is, what is their native language? What is their culture or nationality? What is their sexual orientation or gender identity? What's their age and developmental considerations? What are their roles and responsibilities? What's their social background? What's their social status? Physical, mental, and emotional states. What are their values? And what environment are they coming from? And then we're looking at your nonverbal communication. We send messages to each other through our gestures, our facial expressions, posture, eye contact, clothing, touch, how we appear. Most communication is actually nonverbal. Our body language communicates acceptance, it shows joy, it shows interest, but it also shows when we have fear and discontent. So it's essential that we be aware of how we approach our patients as much as we are aware of how our patients approach us. We must monitor our body language to indicate that we're approachable, that we are interested, and that we are accepting of our patients. So reducing communication barriers. We have to acknowledge and reduce communication barriers so we can promote a more effective relationship with our psychiatric patients. Use words that are appropriate to the patient's education level. Avoid terms that they're not going to understand. And be aware of words that may have more than one meaning. For some patients, the word bad might be slang for good. And if a patient speaks a foreign language or uses an ethnic dialect, make sure that we obtain an interpreter to help us communicate. Remember that a third party's presence with that third party that's helping to interpret may make a patient very less willing to want to tell us what's going on. Patients with impaired hearing, if they can't hear you clearly, they could misinterpret your questions. They could misinterpret your responses. So check whether or not a patient is wearing a hearing aid. And if they are, is it turned on? Can they read lips? It's possible. Face the patient. Always face the patient. Speak clearly and slowly. Enunciate your words with your mouth. Use very common words. Keep your questions short and simple and direct. If the patient has a severe hearing impairment, he or she may have to communicate in writing, and you may need to collect information from family and friends. And with aging, the ability to hear high-pitched tones deteriorates first. For older adults, speaking in low-pitched tones tends to be helpful. Avoid appearing to discount a patient's feelings by changing the subject abruptly. Otherwise, the patient may get the impression that you're disinterested, that you're anxious, that you're annoyed, or that you are judging them. Patients with thought disorders. If the patient's thought patterns are incoherent and irrelevant, they may be unable to interpret messages correctly, focusing on the interview or providing appropriate responses. So when you're assessing them, you have to ask very simple questions about concrete topics to clarify responses. Right? And our paranoid thinkers. For approaching a patient who's paranoid, you have to do it in a non-threatening way. You cannot touch them. It will be misinterpreted as an attempt to harm them. And keep in mind that the patient who is paranoid may not mean any of the things that they are saying. Patient who is hallucinating cannot hear or respond appropriately. You have to show concern, but don't reinforce hallucinatory perceptions. If they're telling you that they see a spaceship, don't say, "Oh, yes, I see that spaceship." You always have to reorient your patients to time, place, and person. Do not feed into their hallucinations. You have to be as specific as possible when giving commands. If the patient says that he or she is hearing voices, tell the patient to stop listening to the voices and to listen to you. Patients with delusions, they will defend irrational beliefs or ideas despite factual evidence to the contrary. And some delusions may be so bizarre that you'll recognize them immediately. And others are kind of hard to identify. But we're not going to condemn, or we're not going to agree with anyone's delusional beliefs. We're not going to dismiss a statement because you think it's delusional. You're just going to gently emphasize reality without arguing with the patient. Patients with delirium, you'll see this often with our alcoholic withdrawal patients. They experience disorientation, hallucinations, and confusions. They misinterpret and they have inappropriate responses. So you need to talk directly, you need to ask very simple questions, and you always have to give frequent reassurances because delirium is reversible. Dementia, on the other hand, not reversible. They may experience changes in memory and thought patterns. Language may become distorted and slurred. And when you're interviewing, you want to minimize distractions. Use very simple, concise language. Avoid making statements that could easily be misinterpreted. And then let's talk about that silence. Silence is a very important tool for open communication. It allows the patient the time and the space to communicate, to think, to evaluate, to process all the challenges that you just brought to them. Remember that even with silence, it's important to remain present in the conversation. Using body language sends a message that you are listening, actively listening and engaging in that conversation. Engaging your patient using eye contact, touch when it's appropriate, gestures send the message that you are actively listening to what he or she has to say. And responding appropriately confirms that you value and you accept your patient. Right, we're looking at congruence. One of the roles of the psychiatric nurse is to assess patients for congruence of their mood, how a patient describes their feelings, their affect, how a patient physically appears. If a patient is describing a distressing occurrence, the nurse would assess for an appropriate affect. The patient might appear sad, they may be tearful. Conversely, if the patient describes something happy or exciting, his or her affect should reflect this by a smile or a pleasant demeanor. And if this isn't what you're observing, that means the patient's mood will be described as incongruent. You're talking about something very happy, yet you look sad, or you're talking about how something terrible happened to you, but you're smiling. Okay, so therapeutic communication, the use of self, is the psychiatric nurse's tool. It's the development of the therapeutic relationship between the nurse and the patient. And this relationship allows for the nurse to complete their assessments and their patient teaching, facilitate conversations, listen attentively to patient concerns. It encourages the development of insight and allows patients to evaluate and develop their problem-solving strategies. Therapeutic relationships are established through therapeutic communication, and techniques that help to establish therapeutic relationships include our open-ended questions, validating feelings, reframing feelings and events, clarifying, refocusing, collaborating ideas, and providing information. And this is all in your textbook during your reading. So non-therapeutic. Let's talk about the therapeutic. So now I have to talk about the non-therapeutic ways of communicating. Non-therapeutic techniques hinder effective nurse-patient relationships. So these are the things I want you to avoid when you interact with patients. Attacking or defending. Do not get angry or argue with a patient. Do not challenge their beliefs. Do not be defensive. Do not cast judgment. Don't judge or criticize a patient. Don't give approval or disapproval. Don't interrogate a patient. Asking mental health patients why questions puts them on the defense. Asking excessive, inappropriate, or leading questions puts them on the defense. Probing sensitive areas or making a patient feel uncomfortable will put them on the defense. So we want to minimize stereotyping the patient. We want to minimize not listening, not taking the patient's beliefs seriously, failing to make eye contact, changing the subject inappropriately, working on a task while the patient is talking to you. That's a big one. Letting your mind wander during the conversation, and then using cliches. We don't give advice. We do not offer false reassurance. We don't pressure patients into accepting treatments that they might not necessarily want. Even if we know it's best for them, they still have the bodily autonomy to make a decision for themselves. We also don't want excessive talking. You don't want to talk on and on and on. You're not letting the patient respond, repeating points that you have already made, interpreting or speculating on the dynamic of the patient's problem, and we don't want to make inappropriate comments. We don't want to rush patients. We don't want to respond to a patient before they finish speaking, and we don't want to finish sentences for the patient. Also, we do not take sides. We don't join attacks led by the patient. We don't participate in criticism of staff members. Right. And looking at open-ended questions or statements. Asking open-ended questions allows your patient to provide you information because it requires more than a yes or no answer. So examples are like, tell me more about that. How do you think you could have handled that differently? Conversational cul-de-sacs are called closed-ended questions, questions that can be answered with a yes or no response. Sometimes they can be a cutoff conversation. They provide very little meaningful information. Sometimes they're needed because a yes or no is all that's needed, but not when we're trying to get more information. Validating. So the practice of validating is reviewing and restating what the patient told you and allows the patient to correct any misunderstanding. But it also assures the patient that he or she has been heard and understood. So that increases that therapeutic relationship and encourages your patient to continue on with his or her story to provide you more insight on what's going on. And then clarifying. At times, a patient can give you confusing or very contradictory information. So you ask the patient to explain what he or she means, allowing your patient to clarify what's being described. Responses such as, I don't understand what you're telling me. Could you tell me about it again? Allows you to evaluate your patient's thought process. You're fostering that therapeutic relationship and you're providing more detailed information and understanding what their concern is. And then sharing impressions. It's important to review what you have heard and reflect back your impression on what your patient's thinking and feeling. So encourage your patient to correct any misunderstandings that may have occurred. A response such as, tell me if this is what you're saying. conveys that you're listening and you wish to fully understand your patient's thoughts and feelings. And then sharing, like restating, allows your patient to correct any confusions, misunderstandings, provides insight to his or her thoughts. And it's important to monitor your response and to share, not to challenge your patient. We do restating, which is almost like validating, where we're reviewing the information that they shared and summarizing the information in our own words to confirm that we understood what they said. This allows the patient to correct the misunderstanding, reinforces that you're interested in listening, encourages continued conversation, and opens an opportunity to provide education on this particular issue. So an example of restating would be, if I understand you correctly, you're saying that you don't like to take medication several times a day. Is that correct? At times, patients can be very disorganized and confused. Helping a patient to focus by asking a question such as, "Can you tell me more about what's bothering you?" allows them to address a particular situation. And our last step is providing information. Psychiatric nurses educate patients regarding medications, interventions, and treatment options, providing information in a way that patients can understand based on their level of literacy, supports a therapeutic alliance, and provides that meaningful guidance to help them manage their condition. But be cautious that we provide, we're not providing advice, but giving education. And that is it for my week lecture on therapeutic communication. Make sure you check out the course announcements for all of the assignments that are going to be due this week, along with your readings that are needed and your ATI modules.